Ngā mihi nui, ko Gordon Royle tōku ingoa. I'm one of the haematologists in Auckland. We've got another 2 here, so there'll be no shortage, and it's going to be, we're on the home straight, as you said. So given trying to convey everything in 10 minutes is a tall order, I'm going to try and stick with just a number of key concepts that you can work everything else out from, and I'm very specifically trying to not say things that are obvious that you already know. So first of all, we'll take 3 cases, but we'll take them on the run. So a 72-year-old who had a hip replacement 4 days ago presents with a sudden onset shortness of breath and pleuritic chest pain. On examination, there is left leg swelling, unsurprisingly, given he's had his left leg operated on. SATs are normal, key point. OBS are normal aside from a mild tachycardia of 90, and he's diagnosed with a large PE. Second case, shifting from an obviously provoked one. This is a 50-year-old who's just flown back from Sydney, and next day his leg is rapidly swelling and painful, and he's got a proximal DVT. You start anticoagulation when you see him. You start with a DOAC, all reasonable. And just before we go to our third and final case, starting anticoagulation, what I would usually suggest are baseline checks. The full blood count will, obviously you want them to have enough platelets before you put them on blood thinners, but also look for signs of bleeding, such as a microcytic anemia, that might tell you that they've gotten some GI pathology that helped trigger that clot, especially in this case where it's a bit suspicious. I check renal function, I check liver function, given that the drugs that you're about to start are liver metabolism, and I do a baseline coag just in case they're already abnormal, and check if they're on any antiplatelet agents, including over-the-counter ones. Not an absolute contraindication. Sometimes if somebody's got horrible joint pain, I sort of say, look, you are taking something of a risk, but you may consider it worth it, and I put them on a slow release, perhaps every 2 or 3 days, non-steroidal. But you have to have that conversation. Important, always check the family and personal history for prior VTEs, because that may influence your duration of anticoagulation. So as in this case, when it's not strongly provoked, as I say, I would look for underlying sinister causes. This could be your chance to catch a malignancy early on when it's treatable or curable. I don't routinely CT scan everyone who has a spontaneous clot. Case 3, a 28-year-old woman, so she's at the extreme other end of the spectrum of provokedness. She's diagnosed with a popliteal DVT. Now, we regard those as being in the same camp as a proximal DVT. They have the same or comparable recurrence rate and complication rate. Past medical history is negative, but there is a positive family history. Her mother had an estrogen-associated clot at a relatively low age. So she hasn't had any thrombophilic challenges previously or now. So you start anticoagulation, you choose dabigatran in this case because you're worried about menorrhagia with rivaroxaban, which we do see quite a lot of. Thing with dabigatran is you do have to have that 5-day leading with Clexane. So taking those 3 cases, the first one's in this category here, where it's a clearly provoked clot. Therefore, once the provoking cause is gone, the recurrence rate is low. It's about 1% only in the first year and 3% at 5 years, which also tells you that the recurrence risk persists over time. It doesn't magically shut off at 1 or 2 years. If it was a less provoked clot, like the second case, immediately the recurrence rate is 5 times higher. This data is from colleague Huyen Tran in Australia. And if it's unprovoked, it's twice as high again when you stop anticoagulation. And if there's a clear persistent risk, such as malignancy or antiphospholipid, it's almost a 50% recurrence risk. So those are the people that we would definitely keep going with anticoagulation. So the concepts are basically, after 3 months, if the thrombus is going to dissolve, it will have, some don't. And that doesn't always mean that the symptoms are worse, far from it. It may mean that they've collateralized and they don't need that clotted off vessel. We see that in people with a duplex system. So if the cause has gone, you can stop anticoagulation. But if there's no obvious cause, we're obliged to consider that whatever triggered it, whether it's built-in thrombophilia or some unknown underlying disease, could trigger another one if you stop. So in that case, we continue. But at this stage, we're not treating the clot, we're preventing a further one. We're treating the risk rather than the clot. Scanning the leg is a good idea because it gives you a baseline in case they present with symptoms in 6 months. But what it doesn't do is tell you whether or not they should continue on anticoagulation. They've already shown form by having a clot, and thrombophilia testing in general won't inform you further normal scanning. The exception probably being antiphospholipid screening, because that will influence the choice of anticoagulant. Specifically, as I say, we usually treat well-provoked VTEs for 3 to 6 months, usually 3 for DVTs and up to 6 months for PEs. Distal, 2 to 6 weeks, and superficial clots, again, about 2 weeks, sometimes longer. And usually when you rescan them, there's still some residual superficial vein clot. Don't expect it to go away. And after they've sort of recurred 2 or 3 times, reluctantly, you sort of end up going, fine, you can be on rivaroxaban 10. And it usually works, but you really feel a bit nervous about having somebody on lifelong anticoagulation just because of a clot in a superficial vein. And there is, as I've just alluded, that option at 6 to 12 months to reduce the rivaroxaban dose to 10 milligrams. Excuse me. Oh, there's water. Yeah, we know that that's effective from a trial we did. Good stuff. Right. The HER2 rule, who's heard of this? Yes, no fair. Okay, so it's fairly old. It sort of dates from the warfarin days, but it's very useful because it's a way of telling you whether you can safely stop that person's anticoagulation. And it's called HER2 because it says men continue if they've had an unprovoked proximal DVT or a PE and HER2. And the HER stands for hyperpigmentation, edema and redness. The D for D-dimers greater than 250, and the 2 O's for oldness and obesity being 65 and 30 respectively. Men just continue anyway. And patient preference has to come into it as well. You'll notice that there is no cognizance of a positive past or family history. There probably should be, but when they did the ANOVA, that didn't feature. And I think I'd have an even lower threshold for continuing now that we have safer and more convenient anticoagulants. There are other predictive systems as well, but this one has the nicety of telling you whether to continue rather than just what your percentage risk is. When you do stop anticoagulation, I suggest that they be protected at times of increased risk, basically major injury, major surgery, major medical illness, although that usually means they're in hospital, so somebody will hopefully think of giving them prophylaxis. Estrogens, especially if it was an estrogen-associated event, and maybe air travel, which conveys a much lower risk. And when people ask us, how effective are these blood thinners? Am I going to get another clot? The figure I usually trot out is they're 80 to 90% effective at preventing recurrence on average. And if a breakthrough occurs, the first thing I would do is question their compliance. Aspirin's only about 32%, so it's a poor substitute, but sometimes it still has a role. Case 3, let's rejig case 3 because we can. It's made up. We can do whatever we want. So she's now... she was on Jeanette. So Jeanette and Diane 35, which I don't think we use anymore, both contain cyproterone acetate, which is quite thrombogenic. So that might have well been what triggered it. It's sort of, if you'd been on it for 10 years, you think, well, it's probably not the Jeanette. But if you started 3 months ago, then that might well be the cause of the otherwise unprovoked clot. So I tend not to do thrombophilia tests, as I've said, because once they've shown form, the risk's there whether or not they've got factor V Leiden, for example. And she probably is safe to continue the pill, although if she could be put on something else, that would be better while she's on anticoagulation. Of course, once the anticoagulation stops, she's not protected against an estrogen-associated event. JDEL is not associated with an increased VTE risk. It's a bit polarising, but it's worth considering under these circumstances, especially when you're going to stop their anticoagulation. And of course, if it is estrogen associated, she should probably be referred to the high-risk antenatal clinic for Clexane during any pregnancy. And also because she's young, you need to counsel her that she must not become pregnant while she's taking rivaroxaban. Not that it conveys the same risk as warfarin, but it's not known to be safe. And we'll fast forward 20 years. She's now getting quite disabling perimenopausal symptoms at a relatively low age. And she asks, and we get quite a few referrals about this. Can she take menopausal hormone therapy? If so, what? I think most of you know about this though, so we'll zoom through it. And can she take her progestogen as well and not have unopposed estrogen? Basically, yes, there's a mildly increased risk, and her family history probably increases that too, but it's still a really low risk. I'll show you the data in a sec. It requires a conversation, essentially. And estradiol, probably because it's transdermal and bypasses the liver, has the lowest risk, so low that in some of the series there was no significant increased risk. It would probably be greater in her than in the average person, though, because of her VTE history. Age is a risk as well. If she's 48, that's a much lower risk than if she was 65 under the same circumstances. Most of the data on this comes from the Women's Health Initiative, and it still isn't granular down to sort of individual cases like hers. As regards progestogen, utrogestan, it's the only micronized natural progesterone in New Zealand, and it's not transdermal. It seems to possibly add a mild increase in VTE risks. But for MHT, there are also health benefits. So I've spelt them out here, and the bottom line you'll see, 5 fewer events in terms of all-cause mortality. But this is number of cases per 1,000 women over 5 years. So it's really very low figures in terms of both risk and benefit. So that's combined estrogen, progestogen. Estrogen unopposed, again, all-cause mortality is significantly lower. So that has to be weighed in when people are worried about their risk of thrombosis. Warfarin, yes, there is still a role for it. Creatinine clearance below 15, where you can't use rivaroxaban, let alone dabigatran, and metal heart valves as well, and people who are triple positive for antiphospholipid syndrome. All those cases, you're busted back to good old-fashioned honest warfarin. How well does it work? This is a heroic study that was done by David Graham in terms of numbers. Basically, each DOAC was better than warfarin in terms of stroke, intracranial hemorrhage, and mortality. However, warfarin is good in terms of GI bleeding compared to both the DOACs that we have here. We don't have apixaban yet. So if somebody says, oh, dabigatran's got this GI bleeding problem, in fact, so does rivaroxaban. Anticoagulation in heavy people, very specifically heavy rather than high BMI. Clexane, we've set the maximum dose to 150, partly because that's the syringe size, but also George's in Australia has quite a lot of data on this now, and because Clexane's largely intravascular, people who have a high weight and a high BMI won't need doses proportional to their actual body weight. So that's why we cap it. Dabigatran, I'd be cautious above 120, but you can always do levels. They'll lab tests / Awanui will send them to Auckland. Rivaroxaban levels may be adequate, even in people up to 150 or 160 kg, because rivaroxaban's 80% plasma protein bound, so it's just sitting inside your veins. High BMI, therefore, per se, is not a contraindication. THANS needs to get on the case. It's weight, which is a key factor. In malignancy, there are 2 options. If somebody has a malignancy and is diagnosed with a VTE, Clexane or rivaroxaban, however, not in cases where there's an unresected GI tract luminal malignancy because of bleeding reasons. Dabigatran, there's no good data, so we don't use it. Reversa, we'll skip through. Basically, I give them the full 10 milligrams of vitamin K because I find if you just give tiddly little 3 milligram doses, it doesn't work completely. And even then, the 10 milligrams may not be enough. If there's the option of giving IV, I would suggest doing that. And obviously, we use prothrombinics and send them to the hospital when it's more urgent.